Sir, you wait in the general waiting area like everyone else.
I'm experiencing severe chest pain. What's the protocol for immediate cardiac assessment?
The protocol is you wait your turn.
On what medical basis are you delaying cardiac evaluation?
I don't need to explain hospital procedures to you.
Which specific triage criteria am I not meeting?
That exchange you just heard happened at St. Mary's Medical Center just past midnight on what started as a routine Tuesday evening. The emergency room was in controlled chaos. Alarms beeping, gurney wheels squeaking across worn linoleum, ambulance sirens wailing in the distance. The smell of disinfectant mixed with fear hung heavy in the air as medical staff rushed between patients. But what made this night different wasn't the usual emergency room drama. It was the man standing at the triage desk, pressing his hand firmly against his chest, sweat beading on his forehead despite the hospital's aggressive air conditioning. His breathing was controlled, measured, not the panicked gasps you'd expect from someone in distress, but the calculated assessment of someone who understood exactly what was happening to his body. Patricia Williams had built her entire nursing career on being the gatekeeper. 15 years in emergency medicine had taught her that the moment you showed weakness, patients would walk all over you. Her performance reviews consistently praised her efficient triage assessment and excellent ability to manage difficult patients. She wore that reputation like armor, especially during nights like this one. 3 nurses had called out sick, leaving St. Mary's Medical Center emergency department dangerously understaffed. Patricia had been running on coffee and determination since her shift started at 6 p.m. Her 15-year career badge caught the hospital's harsh lighting as she moved between stations, a physical reminder of her experience and authority. She dealt with every type of patient imaginable. The drug seekers claiming chest pain to get opioids, the hypochondriacs who Googled symptoms and convinced themselves they were dying, the people who used emergency rooms as primary care because they couldn't afford regular doctors. Patricia had developed what she considered a foolproof system for identifying problem patients. Late-night arrivals in casual clothes were immediately suspect. Young men claiming cardiac symptoms without obvious distress were likely drug seekers. And when someone combined multiple red flags, like the man who just walked through the automatic doors at 12:15 a.m., her defensive instincts kicked into overdrive. She'd seen this exact scenario dozens of times before. They'd demand immediate attention, often becoming aggressive when told to wait. Some had memorized medical terminology from internet searches, using big words to sound more credible. Patricia prided herself on being too smart to fall for these manipulations. Her job was to protect hospital resources from people who didn't deserve them. What Patricia couldn't see, or chose not to see, was Dr. Michael Reynolds. At 42, he was one of the youngest department heads at Johns Hopkins Medical Center, a renowned cardiologist who had just delivered a presentation on racial disparities in cardiac care at the American Heart Association conference in Chicago. The irony would have been crushing if Patricia had bothered to look at his conference materials. Michael had chosen St. Mary's specifically because of its reputation for excellent cardiac care and its prominently displayed diversity initiatives. His flight from Chicago had been delayed 3 hours, and by the time he reached his car in the airport parking garage, the chest pain had started. Not the sharp, stabbing pain of a pulled muscle or indigestion. This was the deep, crushing sensation he'd studied for years, written about in medical journals, and recognized immediately as acute coronary syndrome. The elderly woman sitting in corner chair 7 had been waiting for 3 hours with her own chest pain. Dorothy Martinez, 73 years old, had raised 4 sons and worked as an elementary school secretary for 30 years. She knew how to read people, and something about the interaction at the triage desk was setting off alarm bells in her mind. "That man's not acting right," she whispered to her husband. "Too calm for someone faking. Look at how he's breathing. That's not panic, that's control." Her husband, a retired construction foreman, had seen men try to tough their way through serious injuries. "He's holding his chest like my buddy Carlos did right before his heart attack," he observed quietly. But their voices were lost in the chaos of gurney wheels squeaking across worn linoleum and the constant symphony of medical alarms. Jessica Martinez, no relation to Dorothy, was a 21-year-old nursing student in her first semester of clinical rotations. She'd been thrilled to land a placement at St. Mary's, eager to learn from experienced nurses like Patricia. She'd positioned herself near the supply closet where she could restock materials while observing patient interactions, hoping to absorb the wisdom of emergency medicine. But what Jessica was witnessing didn't match her textbooks. The man at the triage desk was using precise medical terminology, presenting symptoms exactly the way her professors taught clinical assessment. This wasn't how patients talked, this was how doctors talked. She glanced at his briefcase and caught a glimpse of what looked like a Johns Hopkins logo, but she was just a student. Who was going to listen to her observations over a 15-year veteran? The night shift supervisor, Robert Kim, was completely absorbed in trauma bay 2. A 23-year-old motorcyclist had arrived 30 minutes earlier with multiple fractures and possible internal bleeding, requiring every available hand and all of Robert's attention. He was unaware that one of the most distinguished cardiologists on the East Coast was being denied basic medical care just 50 feet away. The security guard position near the entrance had worked hospital security for 8 years. He'd learned to read situations quickly, to distinguish between genuine emergencies and manufactured drama. Most aggressive patients were loud, demanding, threatening. But this man was none of those things. He was asking specific questions, using medical language, maintaining respectful eye contact. Something didn't add up, but Patricia was the nursing supervisor, and he'd learned not to question her judgment. Several other patients in the waiting room were beginning to pay attention to the confrontation. A few discreetly pulled out their phones, sensing something significant was happening but not sure what. Most pretended to look at magazines or study their phones, the way people do when they sense trouble but don't want to get involved. A young mother with a sick toddler moved to chairs farther from the triage desk, instinctively creating distance from whatever drama was unfolding. Michael's professional training was warring with his personal fear. 30 years of medical experience told him exactly what was happening to his body. His coronary arteries were likely blocked, his heart muscle was being deprived of oxygen, and every minute of delay increased the risk of permanent damage or death. But his personal experience as a black man in America told him something else entirely, that pushing too hard, demanding too much attention, could escalate this situation in dangerous ways. The chest pain was intensifying, radiating down his left arm and into his jaw. Sweat beaded on his forehead despite the hospital's aggressive air conditioning. His heart rhythm felt irregular, and he could sense his blood pressure dropping. This wasn't anxiety or indigestion. This was the real thing, the emergency he'd spent his entire career preparing to treat in others. The cruel irony wasn't lost on him. 3 hours earlier, he'd been standing at a podium in Chicago, presenting research on how racial bias in healthcare led to delayed treatment and worse outcomes for black patients with cardiac emergencies. He'd shown slides with statistics about mortality rates, talked about the importance of implicit bias training for medical professionals, urged his colleagues to examine their own assumptions about who deserves immediate care. Now he was living those statistics, becoming one of those data points he presented so clinically to his peers. If this story is already grabbing your attention, make sure you subscribe and hit that notification bell, because what happens next will shock you. The question I want you to think about: what would you do if you witnessed this situation unfolding in front of you? Let me know in the comments. Michael approached the triage desk with his insurance card and identification ready. This was standard procedure, something he'd done thousands of times in his own emergency department at Johns Hopkins. He believed in the system, trusted that medical professionals would recognize a colleague in distress and respond appropriately. His faith in that system was about to be shattered. Patricia's assessment was instantaneous and catastrophically wrong. Late-night patient, casual clothes, black male, every red flag in her mental database started firing. She'd seen this combination before or thought she had. In her mind, these were the markers of someone trying to manipulate the system, someone who would claim chest pain because they knew hospitals had to take cardiac complaints seriously. The waiting room was beginning to buzz with nervous energy. Most patients pretended to look at their phones or magazines, but the tension was unmistakable. A few people discreetly started recording on their phones, sensing that something significant was happening. The elderly woman who'd been waiting for hours nudged her husband and pointed toward the triage desk with growing concern. "Here's my Johns Hopkins Medical Center identification," Michael said calmly, sliding his hospital badge across the counter. His hands were beginning to shake slightly, not from nerves, but from the cardiac event that was progressing in his chest. "And my medical license from the state of Maryland." Patricia glanced at the documents for maybe 3 seconds. Long enough to say she'd looked, not nearly long enough to process what she was seeing. The Johns Hopkins logo was clear, the medical license legitimate and current, but her mind had already categorized this patient as problematic. Anyone can get fake IDs made, she said dismissively, sliding them back across the counter. You can buy anything online these days. Jessica, the nursing student, was close enough to see the credentials Michael was presenting. Even from her position near the supply closet, she could tell they looked legitimate. More than legitimate, they looked impressive. Johns Hopkins was one of the most prestigious medical centers in the world. If this man really worked there, if he really was who his identification claimed, then Patricia was making a terrible mistake. Here's my comprehensive insurance coverage through Johns Hopkins Faculty Insurance, Michael continued, his voice remaining steady despite the increasing pressure in his chest. He could feel his heart struggling, could sense his blood pressure fluctuating, but years of medical training had taught him to maintain professional composure even in crisis situations. Doesn't change our procedures, Patricia replied without looking at the insurance card. She'd made up her mind about this patient, and no amount of documentation was going to change it. Everyone waits their turn. That's how emergency rooms work. Michael tried a different approach, falling back on precise medical terminology. I'm experiencing substernal chest pressure radiating to my left arm and jaw, associated with diaphoresis and mild dyspnea. These symptoms began approximately 45 minutes ago and are consistent with acute coronary syndrome requiring immediate evaluation. The clinical description was perfect, exactly how a cardiologist would present his own case. Every word was medically accurate, the symptom progression textbook appropriate. This wasn't someone who had Googled chest pain symptoms. This was someone providing a professional medical assessment. But Patricia had heard patients use medical language before, usually after spending hours on WebMD convincing themselves they were dying. I've heard people Google symptoms before, she said with barely concealed irritation. You can find anything on the internet these days. Doesn't make you a doctor. Jessica couldn't believe what she was hearing. She'd been studying medical terminology for months, and this man wasn't just using random medical words, he was providing a complete, accurate clinical presentation. This was exactly how her professors taught them to present cardiac cases. She wanted to say something, but she was just a first-semester student. Who was going to listen to her over a 15-year veteran nurse? The chest pain was triggering memories Michael had spent 30 years trying to suppress. Suddenly he was 12 years old again, watching paramedics work frantically on his father in their living room. David Reynolds had been complaining of chest pain for 2 hours before his wife finally called 911. It's probably just indigestion, she'd said, not wanting to bother the doctors with something minor. By the time the ambulance arrived, it was too late. Michael watched his father die on their living room floor, watched the paramedics' faces change from determined to defeated. That night, sitting in a hospital waiting room while his mother cried and his world fell apart, 12-year-old Michael Reynolds decided he was going to become a cardiologist. He was going to save other people's fathers. He'd kept that promise. Over the years, he'd saved hundreds of lives, published groundbreaking research on preventive cardiology, trained the next generation of heart specialists. He'd dedicated his entire career to ensuring that what happened to his father wouldn't happen to anyone else. Now, 30 years later, he was the one having the heart attack. And he was being denied treatment by a nurse who couldn't see past the color of his skin. The pain was intensifying with each passing minute. What had started as pressure was becoming crushing weight, like an elephant sitting on his chest. His left arm was numb now, and he could feel his heart rhythm becoming increasingly irregular. His medical training told him exactly what was happening. His coronary arteries were blocked, his heart muscle was dying, and every second of delay increased his risk of permanent disability or death. Patricia was running out of patience. She had a waiting room full of patients, a skeleton crew to manage them, and this man was taking up time she didn't have. The motorcycle accident in Trauma Bay 2 was consuming most of their resources, and she had 3 other patients who needed assessment. Sir, I've explained our procedures multiple times. You need to take a seat in the waiting area like everyone else. That's when Michael made a decision that would change both their lives forever. Instead of arguing further, instead of raising his voice or making demands, he calmly asked one more question that demonstrated just how serious his situation had become. Can you please call your supervisor? I'd like to speak with someone about this hospital's cardiac emergency protocols and patient rights. Patricia's response was swift and decisive, but not what Michael had requested. Instead of calling her supervisor, she reached for her phone and made a different call entirely. Her voice carried across the waiting room, clear and unmistakable. "Security to triage. I have an aggressive patient claiming to be a doctor. He's refusing to follow standard procedures and demanding special treatment." The words hit Michael like a physical blow. Aggressive patient. He'd maintained perfect composure, spoken with clinical precision, presented valid credentials, and explained his symptoms clearly. He hadn't raised his voice, made threats, or behaved inappropriately in any way. And now he was being labeled as aggressive for the crime of requesting medical care while black. The security guard responded to Patricia's call, approaching the triage desk with practiced caution. In his 8 years of hospital security, he'd learned that most aggressive patients were actually scared patients, people in pain who were frustrated by the system. But this man didn't fit the usual profile. He was sitting calmly, hands visible, making no threatening movements. His posture was professional, almost clinical. Other patients were now openly watching the confrontation. Several were recording on their phones, though they tried to be discreet about it. The elderly woman in the corner was growing increasingly agitated. "Can't you see he's sick?" she called out to no one in particular. "Look at him sweating. Something's wrong with this picture." Jessica was experiencing her first real moral crisis as a healthcare professional. She'd seen the entire interaction, and at no point had this man been aggressive. If anything, he'd been remarkably calm considering he was apparently having a heart attack. She looked at his credentials again: Johns Hopkins Medical Center, one of the most prestigious hospitals in the world. If he really was a doctor there, if he really was having a cardiac emergency, then she was witnessing medical malpractice in real time. Michael recognized the pattern unfolding around him with painful familiarity. He'd lived through variations of this script his entire life, in medical school, during his residency, even as an attending physician. The assumption of guilt, the criminalization of his presence, the way his professional credentials became invisible the moment someone decided he didn't belong. But this time was different. This wasn't about professional embarrassment or hurt feelings. This time the stakes were life and death. "Even here with my credentials, it's happening again," he thought to himself, feeling that familiar mixture of rage and resignation. But the rage was tempered by fear now because he could feel his heart failing in his chest, could sense his body shutting down while he sat in a hospital surrounded by people trained to save lives. The security guard addressed Michael with standard protocol language, even though nothing about the situation appeared to warrant security intervention. "Sir, I'm going to need you to remain calm and cooperate with hospital staff." "I am calm," Michael replied, his voice steady despite the crushing pain in his chest. "I'm a cardiologist experiencing what I believe to be acute coronary syndrome. I'm requesting appropriate emergency medical evaluation." The clinical precision of his language, the professional terminology, the calm demeanor, none of it mattered. Patricia had framed the situation, and once that frame was in place, everything Michael said or did would be interpreted through the lens of him being an aggressive patient who didn't belong. Other patients were quietly leaving the area now, sensing that the situation was escalating beyond normal waiting room drama. The young mother with the sick toddler moved to chairs on the opposite side of the room. An elderly man with a broken wrist got up and walked outside to call his son, unwilling to be a witness to whatever was about to happen. The night shift supervisor was still completely absorbed in the trauma case, unaware that a medical emergency of a different kind was unfolding in his waiting room. The motorcycle victim required his full attention, and he trusted Patricia to handle routine triage decisions. That trust was about to cost a man his life. This is just the beginning of a medical nightmare that will shock the entire healthcare system. Hit that subscribe button now because the next part of this story will leave you speechless. Here's what I want to know. Have you ever witnessed discrimination in a healthcare setting? What did you do about it? Share your thoughts in the comments below. The security guard found himself in an impossible situation. Patricia had called him for an aggressive patient, but the man sitting calmly at the triage desk showed none of the usual signs of aggression. No raised voice, no threatening gestures, no signs of intoxication or mental distress. If anything, he appeared to be in genuine medical distress, sweating, pale, holding his chest. "Sir, what seems to be the problem here?" the security guard asked, trying to de-escalate a situation that didn't seem to need de-escalating. Michael was fighting a war on two fronts. His medical training was screaming that he needed immediate cardiac intervention, an EKG, blood work, possibly emergency catheterization. But his experience as a black man in America was telling him to be very careful about how he responded to security. One wrong move, one word interpreted as threatening, and this situation could spiral completely out of control. "I'm experiencing a cardiac emergency," Michael said slowly, his hands now visibly shaking from the physiological stress of his heart attack. "I've presented my medical credentials and requested appropriate triage evaluation. I'm not being aggressive, I'm trying to get medical care." The security guard looked confused. He'd been told to expect an unruly patient, but what he found was someone who appeared to be genuinely ill, speaking in medical terminology, and carrying what looked like legitimate hospital identification. He glanced at Patricia, who was busy with paperwork, then back at Michael. Jessica, the nursing student, was experiencing her first real ethical crisis. She'd been taught that patient advocacy was a fundamental responsibility of nursing, but she was just a student. Still, she couldn't ignore what she was seeing. Summoning courage she didn't know she possessed, she approached the security guard. "Excuse me," she said quietly, her voice shaking with nervousness. "I don't want to contradict anyone, but I've been observing this situation and something seems wrong. This patient is showing classic signs of cardiac distress, and his credentials look legitimate." Patricia overheard Jessica's intervention and immediately shut it down. "Jessica, you're a first-semester student. You don't have the experience to assess these situations. Please return to your assigned duties." The dismissal was swift and professional, but it left Jessica in an impossible position. She could see that Michael's condition was deteriorating, his skin was becoming gray, his breathing more labored. But she was powerless to act on her observations. The situation might have continued this way indefinitely, but fate intervened in the form of Robert Kim, the night shift supervisor. The motorcycle accident in Trauma Bay 2 had been stabilized enough for transport to surgery, which freed him to check on the rest of the department. When he saw security at the triage desk, he immediately approached to assess the situation. "What's going on here?" Robert asked, his tone professional but concerned. Patricia quickly explained her version of events. "We have a patient claiming to be a doctor, demanding immediate treatment, refusing to follow standard procedures. He became aggressive when I explained our triage process." Robert looked at Michael, who was now clearly in distress. Sweat was pouring down his face, his breathing was shallow and rapid, and he was clutching his chest with obvious pain. This didn't look like someone seeking drugs or trying to manipulate the system. This looked like someone having a heart attack. "What's your name, sir?" Robert asked gently. "Dr. Michael Reynolds," Michael managed, his voice strained with pain. "I'm Chief of Preventive Cardiology at Johns Hopkins Medical Center. I'm experiencing acute coronary syndrome and need immediate evaluation." Something clicked in Robert's memory. He'd seen that name before in medical journals, conference proceedings. Dr. Michael Reynolds was a respected cardiologist, a researcher whose work on cardiac risk factors had been widely published. Robert had actually read some of his papers during his own master's program in nursing administration. "Can I see your identification again?" Robert asked, this time taking a careful look at Michael's credentials. The Johns Hopkins Medical Center badge was legitimate, with security features that would be impossible to fake. The medical license from the state of Maryland was current and properly formatted. More importantly, the name matched publications Robert remembered reading. This wasn't someone pretending to be a doctor. This was actually Dr. Michael Reynolds, a distinguished cardiologist having a heart attack. Robert's training kicked in immediately. "We need to get you to a bed right now," he said, signaling for a wheelchair. "Jessica, can you please get an EKG machine and call cardiology?" But Patricia intervened again, her professional pride now on the line. "Robert, I followed proper procedures. This patient has been uncooperative and demanding. I don't think he's actually experiencing a medical emergency." Robert faced a decision that would define his career. He could defer to Patricia's 15 years of experience and established reputation, or he could trust his own assessment and the evidence in front of him. The fact that a distinguished cardiologist was willing to risk his professional reputation by claiming emergency status in another hospital should have been enough. The visible signs of cardiac distress should have been enough. The legitimate credentials should have been enough. But bias is insidious, and even well-intentioned healthcare providers can be influenced by preconceptions. Robert hesitated, caught between his colleague's assessment and his own observations. That hesitation lasted maybe 30 seconds, but it was 30 seconds too long. Michael's cardiac event, which had been building for over an hour, finally reached its crescendo. The crushing chest pain became overwhelming, his vision began to tunnel, and his heart rhythm shifted from irregular to chaotic. He tried to speak to tell them what was happening, but the words wouldn't come. Then he collapsed. The sound of Michael hitting the floor galvanized everyone in the waiting room. The elderly woman who'd been watching the entire interaction screamed. Other patients jumped to their feet. Jessica dropped the supplies she'd been carrying and ran toward the triage desk. Code Blue Main Triage. Robert shouted into his radio, finally understanding the full magnitude of what had just happened. We need a crash cart now. Patricia stared in horror as the man she dismissed as a fake patient went into full cardiac arrest in front of her. The reality of the situation crashed over her like a tsunami. This wasn't someone seeking drugs or attention. This was Dr. Michael Reynolds, a respected cardiologist who had been trying to save his own life while she blocked his access to care. The Code Blue team arrived within minutes, but the damage was done. Michael's heart had been deprived of adequate oxygen for over an hour. What should have been a manageable cardiac event with proper immediate treatment had become a life-threatening emergency with potential for permanent heart damage. As the medical team worked frantically to resuscitate him, Jessica stood in the corner with tears streaming down her face. She'd known something was wrong. She'd tried to speak up. But she was just a student, and her voice hadn't been enough to overcome the systemic bias that had nearly cost a man his life. Patricia watched in stunned silence as her 15-year career imploded in real time. She'd followed her instincts, trusted her experience, done what she thought was right. But her instincts had been wrong, her experience had been clouded by bias, and her actions had nearly killed a distinguished physician. The elderly woman in the corner was still recording on her phone, capturing every moment of the resuscitation effort. She'd witnessed the entire interaction, seen how Michael had been treated, watched as a medical professional was denied care because of his race. Her footage would soon become evidence in what would be one of the largest medical malpractice settlements in the hospital's history. Robert worked alongside the Code team, his mind racing with the implications of what had just happened. He'd hesitated when he should have acted, deferred to a colleague when he should have trusted his own judgment. A man had nearly died because the healthcare system had failed him in the most fundamental way possible. The irony was crushing. Michael Reynolds, a cardiologist who had dedicated his career to preventing exactly this type of tragedy, had become a victim of the very disparities he'd spent years trying to eliminate. The medical emergency is just beginning, but the real crisis is what this reveals about our healthcare system. Make sure you're subscribed because what happens next will change everything for everyone involved. Let me ask you this. If you had been Jessica, the nursing student who saw what was really happening, would you have spoken up more forcefully? What would it have taken for you to override a senior colleague? Tell me in the comments. The Code Blue team worked with desperate efficiency, but the odds were stacked against them. Michael had been in cardiac distress for over an hour, and the delay in treatment had allowed what could have been a manageable heart attack to progress to full cardiac arrest. The damage to his heart muscle was significant and potentially permanent. Dr. Sarah Rodriguez, the cardiologist on call, arrived within minutes of the code being called. As she worked to stabilize Michael's heart rhythm, Robert quickly briefed her on what had happened. The look of horror and disbelief on her face said everything. You're telling me that Dr. Michael Reynolds, the Dr. Michael Reynolds from Johns Hopkins, was having a heart attack in our waiting room for over an hour? She asked, incredulous. I'm afraid so, Robert admitted, the full weight of the situation crushing down on him. Patricia stood frozen near the triage desk, watching the resuscitation effort with growing horror. The man she dismissed as a drug-seeking fake patient was actually one of the most respected cardiologists on the East Coast. She'd denied him care based on assumptions that had nothing to do with his medical condition and everything to do with his race. Jessica's hands were shaking as she recorded everything she could remember about the interaction. As a nursing student, she'd been taught about the importance of documentation in patient care, but she'd never imagined documenting something like this. Her phone's video of the confrontation would soon become crucial evidence. The elderly woman in the corner, Dorothy Martinez, had captured the entire encounter on her phone, from Patricia's initial dismissal of Michael's credentials to his collapse and the subsequent code blue. At 73 years old, she'd seen enough discrimination in her lifetime to recognize it immediately. She knew this footage would be important. Meanwhile, 150 miles away at Johns Hopkins Medical Center, Dr. Angela Reynolds was finishing up her own late-night shift in the ICU when she received the call that would change her life. Her husband, Dr. Michael Reynolds, had suffered a massive heart attack and was fighting for his life at St. Mary's Medical Center. Angela was a physician herself, an intensive care specialist who understood exactly what the terms massive MI and prolonged code blue meant for her husband's prognosis. She arranged coverage for her patients and began the fastest drive of her life, her mind racing with questions about how this could have happened to someone as health-conscious and medically aware as Michael. Back at St. Mary's, the code team managed to restore Michael's heart rhythm after 12 minutes of CPR. He was alive, but the extent of the damage wouldn't be known for hours or days. He was immediately taken to the cardiac catheterization lab for emergency intervention to restore blood flow to his heart. As the immediate medical crisis stabilized, Robert Kim faced the administrative crisis that was just beginning. He had to notify hospital administration that they potentially allowed a prominent physician to suffer a preventable cardiac arrest due to what appeared to be racially motivated denial of care. This was the kind of incident that ended careers and cost hospitals millions of dollars. The call to CEO Marcus Thompson came at 2:30 a.m. Thompson, a veteran hospital administrator, understood immediately that they were facing a potential public relations and legal catastrophe of unprecedented proportions. Dr. Michael Reynolds wasn't just any doctor. He was a nationally recognized expert on cardiac care whose research had influenced treatment protocols across the country. Patricia was immediately placed on administrative leave pending a full investigation. 15 years of nursing experience, countless positive performance reviews, a spotless record of patient care. None of it mattered now. In 1 hour, she destroyed her career and potentially caused permanent harm to a distinguished physician. The nursing union representative, Jennifer Walsh, arrived at the hospital by 3 a.m. Patricia's case would be difficult to defend, but Walsh had seen good nurses make bad decisions under pressure before. The question would be whether this was an honest mistake or something more troubling. "Patricia, tell me exactly what happened," Walsh said as they sat in a small conference room. "Don't leave out any details." Patricia's account of events sounded increasingly hollow as she told it. Michael had been calm, professional, and properly credentialed. He'd explained his symptoms using correct medical terminology. He'd requested appropriate care without making threats or becoming disruptive. Her justification for denying him treatment became harder to defend with each detail. "But he just didn't look like a doctor," Patricia finally admitted, the words hanging in the air like an indictment. By dawn, Dr. Angela Reynolds had arrived at St. Mary's, where she found her husband sedated and on a ventilator in the cardiac ICU. The cardiologist, Dr. Rodriguez, explained the situation with barely controlled anger. "Your husband should have been in a cath lab within 30 minutes of his arrival," she told Angela. "Instead, he was left to have a massive heart attack in our waiting room because our triage nurse decided he didn't deserve immediate care." Angela listened in stunned silence as the details emerged. Her husband, one of the country's leading experts on preventing exactly this type of tragedy, had become a victim of the very healthcare disparities he'd spent his career fighting. The hospital's legal team was already mobilizing. By 6 a.m., 3 attorneys were reviewing security camera footage, interviewing witnesses, and preparing for what they knew would be a massive liability claim. The elderly woman's phone footage had already been turned over to them, providing undeniable evidence of what had transpired. Jessica, the nursing student, found herself at the center of the investigation. Her first-hand account of the interaction, her attempts to intervene, and her documentation of events would be crucial to understanding exactly what had gone wrong. "I knew something wasn't right," she told investigators. He was using medical terminology correctly, his credentials looked legitimate, and he was showing clear signs of cardiac distress. But I was just a student. I didn't think anyone would listen to me. The story began to leak to the media by mid-morning. A Twitter post from someone who claimed to be in the waiting room went viral. "Just watched a black doctor get denied heart attack treatment at St. Mary's ER because the nurse thought he was faking. He collapsed and almost died. This is America in 2025. The local news stations picked up the story by noon, and by evening, it had become a national scandal. The hashtag Justice for Dear Reynolds began trending as medical professionals across the country shared their own experiences with racism in healthcare. The American Medical Association issued a statement calling for a full investigation. The National Association for the Advancement of Colored People announced they would be monitoring the case closely. Civil rights attorneys began reaching out to the Reynolds family, offering their services. Dr. Michael Reynolds remained sedated in the ICU, unaware that his near-death experience had sparked a national conversation about racism in healthcare. The damage to his heart was significant. He'd lost approximately 25% of his cardiac function and would require months of rehabilitation to return to practice, if he could return at all. Patricia Williams sat in her apartment, scrolling through news coverage of the incident and watching her professional reputation disintegrate in real time. 15 years of dedicated service, countless patients helped, a previously spotless record, all overshadowed by one catastrophic hour of biased decision-making. The hospital's attempts at damage control were failing spectacularly. Their initial statement about reviewing procedures and learning from this incident was met with outrage from the medical community and the public. Stock prices for the hospital's parent company began to drop as investors worried about liability exposure. The aftermath is spreading like wildfire, but we're still not at the end of this medical nightmare. Subscribe now because the legal and professional consequences are going to shake the entire healthcare system. I want to hear from you. Do you think Patricia's 15-year career should have protected her from the consequences of this one incident? Was this an honest mistake or inexcusable bias? Let me know your thoughts in the comments. 3 days after his cardiac arrest, Dr. Michael Reynolds finally woke up in the cardiac ICU at St. Mary's Medical Center. The irony wasn't lost on him. He was now receiving excellent care from the same institution that had nearly killed him through neglect. His wife Angela sat beside his bed, her eyes red from crying and lack of sleep. "How bad is it?" Michael asked, his voice hoarse from the ventilator. Angela, as an ICU physician herself, couldn't soften the medical reality. "You've lost about 25% of your cardiac function. There's permanent damage to your heart muscle. You'll need months of cardiac rehabilitation, and we don't know yet if you'll be able to return to full-time practice." The words hit Michael harder than the heart attack itself. His career, his life's work, his ability to save other people's lives, all potentially ended because a nurse couldn't see past his skin color to recognize a medical emergency. The investigation was moving swiftly. Security camera footage confirmed every detail of Jessica's account and contradicted Patricia's initial statements about Michael being aggressive or uncooperative. The elderly woman's phone video had been viewed millions of times online, sparking outrage across social media platforms. Hospital CEO Marcus Thompson was fighting for his institution's survival. The negative publicity was devastating. Medical school applications were down, prominent physicians were requesting transfers, and donors were withdrawing support. The financial impact was already in the millions, and the legal liability could be catastrophic. Patricia Williams received her termination letter on Friday morning, exactly 1 week after the incident. The union grievance process would take months, but the outcome was inevitable. No arbitrator would overturn the firing of a nurse who had denied emergency care to a heart attack victim based on racial bias. Her nursing license was under review by the state board. The preliminary investigation suggested that her actions constituted professional misconduct serious enough to warrant permanent revocation. At 47 years old, Patricia faced the end of her career and the destruction of her professional identity. The legal proceedings began with a $6.8 million lawsuit filed by the Reynolds family's attorneys. The amount wasn't arbitrary, it reflected Michael's lost earning potential as a cardiologist, his medical expenses, pain and suffering, and punitive damages designed to send a message to other healthcare institutions. The hospital's insurance company took one look at the security footage and the strength of the evidence and immediately began settlement negotiations. This wasn't a case they could win at trial, and a jury verdict could be substantially higher than the initial demand. "We're not just seeking compensation for Dr. Reynolds," explained civil rights attorney David Park, who was representing the family. "We're demanding systemic changes to prevent this from happening to anyone else." The medical community's response was swift and uncompromising. The American Heart Association revoked St. Mary's accreditation for cardiac care training programs. Medical students boycotted the hospital's residency programs. Prominent physicians began declining speaking engagements and consulting contracts with the institution. Dr. Rodriguez, the cardiologist who had treated Michael during his cardiac arrest, found herself questioning everything she thought she knew about her workplace. "I've worked at this hospital for 8 years," she told reporters. "I thought we were better than this. I was wrong." Jessica Martinez became an unlikely hero in the nursing community. Her willingness to speak up, despite being just a student, was held up as an example of proper patient advocacy. Nursing schools across the country began using the case as a teaching tool about implicit bias and the importance of challenging authority when patient safety is at stake. The state nursing board's investigation into Patricia Williams took 6 months to complete. The board found that her actions constituted gross negligence in patient care and conduct prejudicial to the public health, safety, and welfare. Her nursing license was permanently revoked, ending any possibility of working in healthcare again. Patricia appealed the decision, arguing that she had followed hospital protocols and that the bias allegations were unfounded. Her appeal was denied. The board's decision was harsh but clear. The nursing profession demands the highest standards of ethical conduct and patient advocacy. Ms. Williams' actions fell far below those standards. The financial settlement was reached 9 months after the incident. The hospital agreed to pay $6.8 million to the Reynolds family and implement comprehensive bias training for all staff. They also established the Reynolds Center for Equitable Health Care, with Michael serving as director once he recovered sufficiently to return to work. Michael's recovery was long and difficult. The permanent damage to his heart meant he couldn't maintain the demanding schedule of a department head at a major medical center. He took early retirement from Johns Hopkins but remained active as a researcher and advocate, focusing specifically on healthcare disparities and bias training for medical professionals. The incident sparked legislative action in several states. Michael's Law, named after Dr. Reynolds, required all hospitals to implement bias training for emergency department staff and established oversight mechanisms to monitor disparities in emergency care. Patricia Williams never worked in healthcare again. The nursing board's decision was final, and no other state would issue her a license given the circumstances of her revocation. She eventually found work in retail management, but the salary was less than half what she'd earned as a nurse. The financial impact on her family was devastating. In interviews years later, Patricia maintained that she had followed proper procedures and that racial bias hadn't influenced her decisions. But her inability to acknowledge the role that implicit bias played in her assessment of Michael undermined any sympathy she might have garnered from the public or her former colleagues. The hospital implemented sweeping changes to prevent similar incidents. All emergency department staff underwent mandatory bias training every 6 months. Triage protocols were revised to ensure that patients presenting with cardiac symptoms received immediate evaluation regardless of their appearance. Patient advocates were stationed in the emergency department to provide additional oversight. 5 years later, St. Mary's Medical Center had rebuilt its reputation, but at enormous cost. The total financial impact of the incident, including legal settlements, lost revenue, implementation of new programs and reputation management, exceeded $15 million. Dr. Michael Reynolds became a nationally recognized advocate for healthcare equity. His research on implicit bias in emergency medicine influenced training programs across the country. He testified before Congress about the need for federal legislation to address healthcare disparities. "What happened to me wasn't unique," he said in his testimony. "It was just unusually well documented. Every day, patients are denied appropriate care because healthcare providers make assumptions based on race, gender, age, or socioeconomic status. We must do better." The elderly woman who filmed the incident, Dorothy Martinez, became an unlikely activist in her 70s. She spoke at community meetings and healthcare conferences about the importance of being an active bystander when witnessing discrimination. "I may be old, but I'm not blind," she would say. "When you see injustice, you have to speak up." Jessica Martinez completed her nursing program with honors and was accepted into a highly competitive critical care residency program. She credits the incident with shaping her approach to patient advocacy and her commitment to speaking up for vulnerable patients, even when it's difficult. The case became required reading in medical schools and nursing programs across the country. It was studied not just as an example of healthcare bias, but as a case study in how institutional failures, individual prejudices, and systemic problems can combine to create catastrophic outcomes. Years later, when asked what he learned from the experience, Dr. Michael Reynolds' answer was both simple and profound. I learned that credentials don't protect you from racism, but they can give you a platform to fight it. My heart attack nearly killed me, but it also gave me a new purpose, making sure this never happens to anyone else. The incident at St. Mary's Medical Center became a watershed moment in discussions about healthcare equity. It proved that even in life-or-death situations, racial bias can override professional judgment and medical evidence. But it also showed that accountability is possible, that institutions can change, and that individual actions, like those of Jessica Martinez and Dorothy Martinez, can make a difference. Patricia Williams' career ended that night in the emergency room, but the conversation she unwittingly started continues to save lives across the country. Sometimes the most important changes come from the most painful failures. This story reveals how deep-seated bias can turn a medical emergency into a near tragedy, but it also shows how accountability and change are possible. If you found this story important, please subscribe and share it. Stories like this need to be told. Final question: what concrete steps do you think hospitals should take to prevent incidents like this? Your ideas in the comments could help save lives.